Hello. Good evening. Respected President Dr. Mohit Shah, Secretary Dr. Rima Bhatt, our past President and today's faculty Dr. Bimal Sahani sir, and all the delegates. We, on behalf of the SFM Northeast chapter, welcome all of you to this webinar. In fact, this is the third webinar of SFM Northeast chapter after we took over our charge. And first webinar was on posterior fossa anomalies and second one on limb anomalies. Today's topic is ventriculomegaly revisited, and we are extremely thankful to our past president, respected Dr. Bimal Sahani sir, for accepting to deliver the lecture on fetal ventriculomegaly revisited from basics to recent updates. And we have got three presenters today on that is a case-based presenter. And for Bimal Sahani, all of you know Dr. Bimal Sahani sir. He is a immediate past president. He's from Aurangabad, and he's an excellent teacher and a fetal medicine expert. He is very much active also, and whenever we ask something, he never says no. So today's expert, Dr. Mohit V. Shah and Dr. Rima Bhatt. Dr. Mohit Shah is the president and Dr. Rima Bhatt, they are the expert today. And for case-based presenters, we have Dr. Bhargav Das from Guwahati, Dr. Zora Ahmed, who is the executive member of SFM Northeast chapter from Guwahati, and Dr. Goto Carlo from Itanagar, Arunachal Pradesh. They will be presenting 3 cases. So with these words, I like to welcome all of you and request our faculty, Dr. Bimal Sahani sir, to start his lecture. Thank you. Sahani sir. Bimal sir.
Yeah, thank you. Thank you very much for those kind words of introduction, Dr. Apurva. And let me share my screen. Where is this gone? One second.
So meanwhile, as Dr. Bimal gets it going, for those, I'm sure there's nobody who doesn't know him, but for those who do not know, Dr. Bimal has probably simplified the concept of color Doppler for all of us. So whenever you hear any talk on Doppler in India, I believe some of them have definitely taken Bimal's slides somewhere down the line, because his approach is very methodical, simplified, and therefore easy to understand. So I myself understood Doppler very well from his approach. And this is the Doppler's the fetal heart, and now ventriculomegaly is very close to his heart, as I know. So he's further gone into more and more research of ventriculomegaly, and today is going to take us through from basics to what the recent updates says, but again, it will be Bimal style, a very methodical 10-step approach for all of you to enjoy. Happy learning.
Thank you, Mohit. And okay, so at the very onset, thank you, the SFM Northeast chapter for having me for this webinar, and as Mohit said, a topic which is close to my heart. And so in the next 45 to 50 minutes, let me take you through ventriculomegaly, the diagnosis, evaluation, and counseling. And okay, I call it a 10-step approach. Now, what is, ventriculomegaly as such is something which is quite commonly seen. It is seen in 0.3 to 1.5% of all fetuses at mid-gestation. It's the most common abnormal fetal cerebral finding that you would see. So if I think anybody who has been doing ultrasound for maybe even 6 months or 1 year, and if you look at the cerebral findings they see, you will find that the most common cerebral finding is ventriculomegaly. And, right in the beginning, let me tell you that I'm using the word cerebral finding. I'm not saying a cerebral diagnosis. It is not an anomaly per se. It actually signals to the possibility of associated anomalies of the brain and other organs. Hence, it's a finding. It's a starting point, which tells you that, yes, there is a possibility of associated abnormalities of the brain and other anomalies, other organs. It can be associated with chromosomal anomalies and infections. The male to female ratio is 1.7:1. And by definition, what is ventriculomegaly is actually excess amount of fluid in the lateral ventricle within the developing cerebrum. We know there is normally also there is fluid in the lateral ventricle, but whenever this is excess, then we say this is ventriculomegaly. And when do we call it as excess? When the atrial width in the axial plane, when the atrial width is more than or equal to 10 millimeter across the atrium of the posterior horn from second trimester onwards, we label it as ventriculomegaly. Now, this is a universal consensus on this. Even, that separation of 3 millimeter of, there was a time when they said, okay, the choroid plexus, then from the medial wall of the LV, if the choroid plexus is separate more than 3 millimeter, then that is also ventriculomegaly. Or if you see a dangling choroid plexus. Now, see, that is something that you will obviously see when you have an atrial width more than 10 millimeter. But for all practical purposes, the definition is an atrial width of 10 or more in the axial plane. Now, MRI often overestimates the degree of dilatation. Now, this probably happens because of a lower spatial resolution, but yes, that is something which we need to be aware of. Now, does fetal sex matter? Yes. Now, there are studies which have shown that male fetuses have a slightly larger atrial size than female fetuses. Now, this definitely has an implication, for defining the upper limit of normal size for ventriculums of the lateral ventricles. But of course, we use a universal size of 10 millimeter to define. But maybe in borderline cases, this is something that also we need to keep in our mind when we are, though we don't look for the sex of the fetus, but then you need to keep it in our mind when we are counseling the patient. Now, see, there are two terms, ventriculomegaly and hydrocephalus, and a lot of people try to use this, keep using them as one and the same. But remember one thing, the term hydrocephalus has to be used only when there is a primary or secondary obstruction leading to increase in the endoventricular pressure. So when the cause is obstructive, that is the only time when we use hydrocephalus. Usually they will have, severe ventriculomegaly greater than 15 millimeter. The primary cause is aqueductal stenosis. Secondary causes could be obstruction, which happens either due to within the ventricle, like intraventricular hemorrhage, or external compression that can happen because of arachnoid cyst or tumors. It's very important that, because I said it's just a finding. We are going to look for a diagnosis, so we need to know the etiology. Now, the etiology could be CNS structural anomalies, could be aneuploidies or other chromosomal associations, could be in utero fetal infections, or intracranial hemorrhage, or genetic and non-genetic syndromes. And if you look into this, I have just put them into 4 separate sections, where malformative causes like the ACC, holoprosencephaly, the MCD, or the Dandy-Walker malformation. Obstructive causes could be an intracranial tumor, aqueductal stenosis, or midbrain hindbrain malformations. You can have clastic things cause where you could be because of infections, ischemia, or intraventricular hemorrhage, or it can happen because of overall an atrophy of the brain due to metabolic disease, neurodegenerative disorders, or blood-stealing lesions following the single fetal demise in a monochorionic twin pregnancy. It's important that we know the etiology, because that is the time, that is how your mind starts working, and you start looking for the cause for ventriculomegaly. And there is a huge chunk of syndromes that could where ventriculomegaly is an association. Now, actually, I could only put this many in one slide, but these are the common ones which could be associated. But that there is, I think, ventriculomegaly is something which can be associated with any CNS anomaly, or in fact with any extra CNS anomalies also you could find ventriculomegaly as an association. So the step one. Now you may say, why am I starting with, is ventriculomegaly in fact present? That is the first step that you need to see, because mild ventriculomegaly is among the most frequent false positive diagnosis at ultrasound. And this usually happens because of a wrong technique. In my practice, then at least there are 30 to 40% of the patients coming to me for a neurosonogram because of a diagnosis of a mild ventriculomegaly, in fact, do not have a ventriculomegaly at all. And hence, you need to be very, very sure about how you're going to measure it. There is a clear-cut criteria. You need to have the head in an axial plane. The image should be magnified so that only the head is what you are seeing, and the focal zone should be at the right place, and the atrium and the occipital horn should be clearly imaged. So when we talk about the three planes, basic planes, we have the transventricular plane, and that is the plane that you need to look into, and you need to see to it that the occiput and the atrium is clearly visualized. And where do we measure it? That's again the maximum issues happen. The wrong diagnosis happens because you are measuring it at the largest diameter that you are seeing, but it needs to be measured at the level of the dip in the parieto-occipital sulcus. Now, this is the parieto-occipital sulcus. This is the dip in the parieto-occipital sulcus, and this is the place where you need to measure it. But you may not see the parieto-occipital sulcus before 20 weeks, and hence now even the new guidelines say that you should measure it at the glomus of the choroid plexus. That is where the choroid plexus ends. That's a glomus, and that is where we need to measure it, and it should be measured perpendicular to the ventricular axis. It should not be perpendicular to the midline, but perpendicular to the ventricular axis. And the measurements should be on to on. By on to on, what I mean is we use the plus caliper, and the horizontal limb of the plus caliper should be on to, like the same way we do it with the nuchal translucency. It's not mid to mid, not outer to outer. It should be on to on. And the problem is that the distal ventricle is very nicely imaged, and you can measure it as per the perfect the criteria that I've talked about. The problem comes is because of acoustic shadowing, you will not be able to see the near ventricle, and you need to measure both the ventricles, and hence you need to tilt the probe a little bit, tilt it posteriorly, and then turn the probe caudally, and you will get to see the near ventricle also, and then you can measure that. Now remember, out of 30 years of experience, I would like to say, okay, as long as it's within the normal range and appearing similar to the distal one, but if you find that it is just borderline, then always try to wait for the fetus to turn and let this side become the one which is distal, because that is the time when you will actually get the most accurate measurement. The second step is to grade the ventriculomegaly. Now, how do we? Now, there has been for quite some time, a lot of authors have said that we need to grade them only into 10 to 15 as mild ventriculomegaly and greater than 15 as overt or severe ventriculomegaly. But even the current studies which have come, there are a lot of work which has been done, and they prefer to use it as 10 to 12 as mild ventriculomegaly, 12.1 to 15 as moderate ventriculomegaly, and greater than 15 millimeter as overt or severe ventriculomegaly. I think this classification is very, very important. It is much better than the previous one, because there is enough evidence to say that the outcomes in 10 to 12 and 12.1 to 15 is different, and hence we should use this classification, classifying it as mild, moderate, and overt or severe ventriculomegaly. Step 3, whether this is unilateral or bilateral. Now, unilateral is not rare. In fact, 30% of them you would find that they are unilateral ventriculomegaly, and the cause usually could be either infections or hemorrhage, or maybe partial agenesis of corpus callosum, or it could just be an isolated thing. Now, one study which came in 2017, where they found out, it was a systematic review and meta-analysis, but what they found out was that in apparently isolated unilateral ventriculomegaly, the incidence of chromosomal abnormality was 0%, congenital infection was 8%, the progression during pregnancy was 5%, additional finding on MRI was 5%, and neurodevelopmental delay was 6 to 7%, which you normally also get in the normal population. So this actually tells us that yes, it is not too worrisome, but we need a lot of work on it. Today, we consider unilateral and bilateral. Our approach is the same. Whether it's unilateral or bilateral, we go ahead and follow the same protocols as we need to do with bilateral ventriculomegaly. The fourth step is whether it is symmetric or asymmetric. Now, when do we say it is asymmetric? When the difference is greater than 2 millimeter. Now, between symmetric and asymmetric, actually asymmetric is worst. The prognosis is bad because usually it is associated with ischemic or post-inflammatory causes, so the prognosis is not good. But the symmetric ones are the ones which are associated with more CNS findings than the asymmetric one. The fifth step is the most important. Now look for other CNS anomalies and findings. So you got a finding, you started your scan, you got a ventriculomegaly, it's more than or 10 millimeter, you have found out that it is symmetric or asymmetric. The most important thing starts now, that you need to look for other CNS anomalies, and hence you look into your 3 basic planes. You need to, the ones that we normally do, look at all the 3 basic planes, look at the structures that we normally need to look for in the basic evaluation, and then move on to an extended neurosonogram. So a very important indication for an extended neurosonogram is a ventriculomegaly seen on your basic screening. And then you have the protocols for that, and you have to take the mid-sag view, the 2 para-sag views, and the 4 coronal views, the transfrontal, the transcaudate, the transthalamic, and the transcerebellar. So you need to do this complete workup, and you need to have a checklist of what all will you look for. So like the head, you need to look at the biometry, the calvarium, and the shape, lateral ventricle, the size, shape, margins, choroid plexus, the size and echo pattern, the lateral ventricular fluid content, the 3rd and the 4th ventricle, the CSP, the corpus callosum, cerebral hemispheres, the subarachnoid space, cerebral parenchyma, whether there is any thinning, clefts, sulcation, and the posterior fossa for the look at the cerebellum, size, shape, symmetry, the vermis, any increased fluid in the posterior fossa. So this is a complete checklist that you need to complete, because then it is only then you will be able, if you find everything normal, then it's only then you will say that this is an isolated stuff. So from the cranial biometry, yes, you can detect microcephaly, where you have the head perimeter which is less than 3 standard deviation below the mean, and when you're looking at the head itself, you will find that you can at times see defects like the encephalocele. Now, let me take you in the next few slides. Just looking at the ventricles, even a good look at the ventricles can give you a clue to what is the cause behind it. So, it's not just about the size, the shape, the wall echogenicity, nodularity, the contents, the periventricular space, and the choroid plexus. All these can give you a clue towards the etiology, because my interest at this moment is to know whether there is a CNS abnormality which is the cause for the ventriculomegaly. So, like, if you look at the shape, if you find that the shape is teardrop, then think of agenesis of corpus callosum and go ahead and look for the mid-sag. If you find that the shape is the posterior or the occipital horn is pointed, it is showing this is a normal occipital horn, and you will find that this is like nice circular, and here you can find that the occipital horn was pointed. Think of neural tube defects. And as I go a little posteriorly, I find the banana sign which is present in an open neural tube defect. If you find that the medial wall of the lateral ventricle is parallel. Now, normally the medial wall of the lateral ventricle will show you a curved, it's a curved, it is curved like this. It's a more like an extended S shape. That's the medial wall. But here you can see that the medial wall is parallel. So if you have a medial wall which is parallel, then think of again the agenesis of corpus callosum. Now, if in looking at the shape of the ventricle, you find that the frontal horns are pinched, then again think of corpus callosal agenesis. If then you're looking at the periventricular space and contents, if you find that there is periventricular echogenicity and you're finding intraventricular septations, think of CNS infections. If you find that there is increased wall echogenicity or there is a heterogeneous choroid plexus, everything is looking dirty, then think of hemorrhage. Again, these things also tell you, because usually they appear later on in pregnancy. And when you find something like this and you find out that your previous scan at the 20 weeks showed normal, again, there are only two causes that can be there. It could be either hemorrhage or infection, which could lead to this kind of a dirty appearance. And look at the wall. Now, if you are looking at the wall and the content, and if you find that the wall is irregular, and then you are seeing nodularity there, think of neuronal migrational disorders or disorders of cortical malformation like periventricular nodular heterotopia. So it is just I've not moved out of the lateral ventricle. I'm still within the lateral ventricle, and that itself is giving me so many clues. And look at the choroid plexus. Sometimes you have a very, very large choroid plexus cyst, and that can also give you a ventriculomegaly, where you find that the atrial width is more than 10 millimeter. Of course, here this was 9.5 millimeter, but appearing prominent because the choroid plexus cyst itself is about 15 millimeter by 11 millimeter, or a mass in the choroid plexus like a choroid plexus papilloma could be a cause. Having done that, so what you have done is you started with the lateral ventricle itself, and looking at the lateral ventricle, it has given you so many clues that could lead to an etiology. Then look at the CSP. Very important structure. Look at the midline and the CSP. If you find that the CSP is absent, think of agenesis of corpus callosum. Then look at all the indirect signs, and then look for do a mid-sag. And here you can see I'm seeing the vermis, but I'm not seeing the corpus callosum. There is no pericallosal artery that is made out, and I have a diagnosis of agenesis of corpus callosum. And if you have a short and a wide CSP, then that is a marker for a partial agenesis of corpus callosum. And there you can see, look at the CSP. This is a square-shaped CSP, and you have just a partial appearance of the corpus callosum. You do not see the posterior body and the splenium. It's just a little part of the anterior body that is seen. So the diagnosis which comes over is a partial agenesis of corpus callosum. Now, why I say this is so important, because if you look at the relationship of callosal abnormalities with ventriculomegaly. Now, in this large study, they found out that the callosal abnormalities were detected in 13% of the fetuses which were referred for ventriculomegaly, and that's quite large. So it's one of the major causes that you get when you have a case of ventriculomegaly, and it was isolated in 20%. The remaining were complicated with other CNS or genetic abnormalities, and 5% which were diagnosed prenatally as having isolated callosal abnormality had other CNS findings on postnatal assessment. Then look for, when you're looking at the CSP and you find that the CSP is absent, but then if it is associated with fused frontal horns, that can be because of minor forms of holoprosencephaly, which here, like you can see that even there is the interhemispheric fissure in the frontal aspect is absent, and there's just a communication that you see in the frontal horns there. The CSP is absent. The other causes could be septal agenesis, which could be either isolated septal agenesis or septo-optic dysplasia, or a seasoncephaly, which can like you have these kind of clefts, and in these cases also you can have an absent CSP. Look for abnormal shape of the cerebellum. If it is banana shaped, you've gone into the posterior fossa, then think of Chiari-2 malformation and go down and see whether there is a meningomyelocele or an open spina bifida, or it could be, if the shape of the cerebellum is globular or triangular, it could be because of a rhombencephalosynapsis. If you find that there is increased fluid in the posterior fossa, because the posterior fossa again is a very, very important entity when we are evaluating for ventriculomegaly, then there are 4 things that can happen. You can have a Blake's pouch cyst, a Vermean hypoplasia, a Dandy-Walker malformation, classical, or a megacisterna magna. You need to differentiate between these. So you need to do a mid-sag, you need to measure the BV angles, and the brainstem tentorium angle, and here you can see this is just a simple Blake's pouch cyst that you are seeing here. Here you can see that the tentorium is elevated, the vermis is very, very small. We are dealing with the Dandy-Walker malformation. Here, this is a megacisterna magna that you are seeing. And the subarachnoid space. If the subarachnoid space is increased, then we are dealing with cerebral atrophy. And again, this can happen with infections. The causes can be others, but yes, here you can see the subarachnoid space which is increased, and if the subarachnoid space can get obliterated in obstructive hydrocephalus. The cerebral parenchyma. Having done this, look at, you're looking at the parenchyma, look for any clefts which could suggest seasoncephaly, look for the sulcation. I'll come to that in the next slide. Look for any parenchymal solid or cystic lesions like porencephaly, tumors, bleed, parenchymal calcifications, which will go in favor of infections. So, a good look at the cerebral parenchyma is important. You need, if you find that there is delayed sulcation, then we are dealing with lesioncephaly. Premature sulcations could be because of polymicrogyria. And when we are talking about malformations of cortical development, they definitely have a good association with mild ventriculomegaly or mild to moderate ventriculomegaly. Here you can see that we are dealing with a moderate bilateral ventriculomegaly. Now this is 25 weeks, and I'm not seeing the parieto-occipital sulcus at all. This is the kind of parieto-occipital sulcus which I will be seeing somewhere around 21 weeks. But by 25 weeks, it would be forming for kind of a V. And look at the Sylvian fissure. And here there is no, it should be obtuse by then. You're just seeing a little elevation in the Sylvian fissure, telling me that we are dealing with delayed sulcation, telling me that the malformation of cortical development is the cause. And again, here you have mild ventriculomegaly, but when I'm looking at the ventricles, doing a transvaginal, and you are seeing that you can see this nodularity, giving me a diagnosis of heterotopia. Now, I mean, if you look at all this, the one message that I would give is when you're doing an extended neurosonogram, see to it as far as possible. If the fetus is in a cephalic presentation, you need to do a neurosonogram transvaginally, because what images you're going to get, what information you will get from a transvaginal may not be as good in a transabdominal neurosonogram. Obstructive hydrocephalus, yes, aqueductal stenosis is the cause, the primary cause for that. You will have severe ventriculomegaly. The head circumference may be more. There will be cerebral parenchymal thinning. The sulci are effaced, and you can have compression or obliteration of the CSP, and hence you may not visualize the CSP. A dangling choroid, that is what you will classically see in this, and the third ventricle will also be dilated in aqueductal stenosis. And remember one thing, when you have a severe hydrocephalus, or then at times you would find that the choroid plexus from one side is going on to the other side. So there is a disruption in the falx. Now, don't label this as holoprosencephaly. This is happening because there is an acquired communication between the lateral ventricles. Because of the pressure, intraventricular pressure, there is a disruption of the falx, and hence you find that the choroid plexus is dangling from one side across this ruptured falx there. So my approach to CNS anomalies in my practice is, the moment I see ventriculomegaly, first I go and look at the posterior fossa. And if I find that the posterior fossa is, whether it's normal or abnormal, if it is not normal, then of course I'm going to look for the causes, Dandy Walker, Chiari 2, rhombencephalosynopsis, or an obstructing mass there. If the posterior fossa is appearing normal, the next thing I go for is midline structures, the falx and the CSP, whether they are present and they're normal. If they are not normal, then what I'm going to see is that you have there are two hemispheres which are seen. If there are two hemispheres which are seen, then we'll look for the ACC or the corpus callosal dysgenesis or septo-optic dysplasia. And if I find that there is, there are no two hemispheres, there is a communication between the two sides, then I'm going to think on the holoprosencephaly spectrum there. And if the midline structures are present and they are normal, then I will start thinking in terms of malformation of cortical development, ischemia, infections, looking at the cerebrum, the cerebral parenchyma and all, and also look for changes of aqueductal stenosis. So you've done your CNS evaluation. The step 6 is look for extracranial anomalies and soft markers of aneuploidy. Because if you look at the extracranial anomalies, it is, for all this syndromic, there can be a lot of association between the ventriculomegaly. There could be associated CNS anomalies also, and there could be CNS anomalies also. And when you put all this together, you may come to a syndromic diagnosis, and also you would know exactly what genetic test you need to perform. Now here you can see that there is a mild ventriculomegaly. Now this is 27 weeks, and I'm not seeing the parieto-occipital sulcus or the Sylvian fissure. Well, there is Dandy Walker malformation, there is facial dysmorphism, and you are seeing that there is a bilateral anophthalmia. There is a bilateral severe microphthalmia or an anophthalmia. You're not seeing the orbits at all. And there is facial cleft, lip, and palate. So putting all this together, yes, the thought process comes that probably I'm dealing with a Walker-Waber syndrome. So looking at the extracranial anomalies becomes important. At times, you may not find the CNS anomalies, but you may find extra CNS abnormalities. And that could be one of the associations that you're going to get. And hence, that is something that we need to look for. Having done all this and you don't find anything, so when no cause is found, should we call it as an isolated ventriculomegaly? No. At this moment, we will call it as an apparently isolated ventriculomegaly or isolated ventriculomegaly on ultrasound. So because this actually represents by definition a provisional diagnosis of exclusion. So you have excluded other things, but the counseling is difficult because this ventriculomegaly just can be a benign finding, but it could be associated with unknown pathologies carrying a poor prognosis. There could be genetic associations and fetal infections, so we need to rule those out. This could be a subtle indicator of certain cerebral lesions that cannot be predicted at this stage, but you may find out in the later scans, as because brain is a structure. A brain at 20 weeks and a brain at 24, 26 weeks is different, and brain at 30 weeks is different. And then isolated ventriculomegaly may be associated with fetal abnormalities. Overall risk for a false negative diagnosis is 12.8%. And hence, this for me at this moment is an apparently isolated mild ventriculomegaly. And hence, my step 7 is reporting. So when I report at this stage, I will first say, yes, okay, ventriculomegaly, whether it's mild, moderate, severe, whether it's unilateral or bilateral, symmetric or asymmetric. And then I will try to talk about what are the associated abnormal CNS findings or extra CNS findings. Only when I don't find anything, then I will say that in this case, the ventriculomegaly appears as an isolated finding on ultrasound. Now, this can be a pointer to an underlying cranial abnormality, which may become apparent later in pregnancy. It can reduce, it can remain static, or it can increase. Progressive ventriculomegaly makes the prognosis poor. Mild ventriculomegaly is a soft marker of trisomy 21, and as an isolated finding, it has an LR of 3.8. It can have other genetic associations. It can be associated with maternal infections. Then I'll put in my suggestions, a torch test, amniocentesis, QFPCR microarray, or whole exome sequencing, whatever I'm thinking of at that moment. And I will say follow up at 3 to 4 weeks and serially if required to look for any progression and to rule out disorders of neuronal migration, SOS MRI. And I will also put a statement saying that isolated mild ventriculomegaly that is not progressive and after having ruled out everything can have a normal outcome in a large proportion of cases. So this is all what I'm talking to the patient, but at the same time, you should put it on paper also. Step 8 is further testing for etiology and associations and further testing. Now, when I look at this, this chart, which all of us use for the trisomy 21, the Hydrocephalus study, which has come up with what is the likelihood ratio, and you will find that the likelihood ratio of ventriculomegaly as an isolated finding is 3.81. Usually it is the mild to moderate which can be markers. When you have severe ventriculomegaly, usually they are not a marker for trisomy 21 as such, but this is something which we know is there. And when there is an overt ventriculomegaly, the genetic considerations can be different, and amongst them the most important one is an X-linked hydrocephaly, which can be seen in 5% of these cases. Here you need to ask for the family history of neurodevelopmental delay in the males in the family. If you look at this, it happens in the male sex, and you can find hydrocephalus, severe ventriculomegaly or hydrocephalus, and an adducted thumb. The recurrence risk is 50% of males. And in the remaining overt ventriculomegaly, the cause could be a multifactorial. Should genetic testing be offered in isolated mild ventriculomegaly? Now, large number of studies have shown there is an association with chromosomal abnormalities, mainly trisomy 21. But the problem is the incidence is, the true incidence is uncertain because the populations are different, the protocols are different. But some studies have shown that 5% of fetuses may have an abnormal karyotype, and another 10% have abnormal findings on chromosomal microarray. Hence, prenatal testing needs to be suggested. And we have a battery of tests. You have the QFPCR, FISH, karyotype, microarray, the NGS, the whole exome sequencing that we talk about, or the clinical exome. What test should you offer? Now, this depends on associated findings, because if your associated findings tell you that we are dealing with probably some single gene disorder, definitely I'm going to go for a whole exome sequencing there, or a panel test for that particular thing. But on a general, cases, you will find it's, you can do a QFPCR for a quick fire ruling out trisomy 21 with chromosomal microarray. This is what is established at the moment. When there are associated findings, you do a whole exome sequencing. But my next slide is going to tell you something different. Should whole exome sequencing be offered to all cases of ventriculomegaly? Definitely when there are associated anomalies or there is moderate to severe ventriculomegaly, even if it is isolated. But for isolated mild ventriculomegaly, at this moment, it is controversial. But I don't think it will remain controversial few years from now. But even today, this particular study, which came in 2022 in fetal CNS anomalies, when should we offer whole exome sequencing? And they found that a pathogenic or a lyclopathogenic variant was found in 13% of the cases, and hence it is justified. This study gives you enough evidence to support the use of whole exome sequencing in all degrees of ventriculomegaly, including isolated ventriculomegaly. But then every country, every region may have its own protocols, and we need to go according to that. Let's look at this case. Here, this was a case of mild ventriculomegaly. Actually, this patient underwent 3 scans in the last 1 week, and somebody said 9.7, somebody said 10.1 to do testing, not to do testing because of that. Now, okay, they came to me, of course, there was a mild ventriculomegaly, 11 millimeter and 10.8 millimeter bilateral. But what was more important was that there was a perimembranous VSD, there was aberrant right subclavian artery. Now, when all these things come together, definitely this is clear-cut a case where you need to do testing, and we found out trisomy 21. So the lesson, this is my statement which I give in most of my talks, is that there is no genotype without a phenotype. So when we think of genetic testing, before even we start thinking of what test to do, our phenotype, you need to do a deep phenotype. Look at things, do a good neurosonogram, do a fetal echocardiography, try to find findings. And because once you find additional findings, the importance of the test, what test to do will change. Also, the interpretation of the genetic test report becomes different when you give them, more phenotypic features in your ultrasound. Fetal infections, yes, 5% of cases of mild to moderate ventriculomegaly are reported to result from congenital fetal infections, including CMV, Toxoplasma, Zika, and since the time the Zika pandemic took place, epidemic took place, even today when you open up, microcephaly or ventriculomegaly, recent articles, you will find a lot of reference to Zika coming in, because since this suddenly became a very, very important after the epidemic of Zika. Now, this is caused due to cerebral atrophy, aqueductal stenosis, due to ependymal fibrosis, or communicating hydrocephalus due to inflammation of arachnoid granulation and excess production of CSF. Hence, we need to do a maternal serology, and otherwise, anyway, if you're going to do an amniocentesis, you can do a PCR for CMV and also, but your maternal serology is very important. Just doing a maternal serology is not important. You should know how to interpret the TORCH report, and if you find that the IgM for that is positive and the IgG is negative, then this is definitely a recent infection for the first time, and expect severe sequelae because of this. And if you find that the IgM is positive and the IgG also positive, this could be recent infection with development of some immunity, or could be a reinfection. That is the time you also need to do the avidity, and hence always do TORCH with avidity. And if the IgG avidity is low, that means it is a recent infection. If it is in high avidity, it is an old infection which is greater than 3 to 6 months. Should an MRI be done for every fetus with ventriculomegaly? See, MRI is definitely complementary to ultrasound, gives marginal superiority. It is good in cases of poor sonographic penetration and the fetus is in a bridge presentation. You're not able to get a good neurosonogram done because of the fetal position, because of a bridge position. And so you're not able to do a TVS. Definitely MRI is indicated. Now, studies have said that MRI it gives additional finding in 16 to 24% of the cases as compared to ultrasound. But you need to look at, I don't believe into this figures because the comparison has to be perfect. The competence of the operator, the competence of the ultrasound person, and the competence of the MRI guy. Whether the ultrasound which was done was just a routine ultrasound, or was it a neurosonogram which was done transvaginally by an expert, then if you compare with MRI, you will find different readings. And what is the gap between ultrasound and MRI? Because you do an ultrasound at 20 weeks, you say there is a mild ventriculomegaly, okay, nothing else is being found. And then because you do an MRI at 26 weeks, yes, you're going to find, you may find malformations of cortical development at that time. But if you would have done an ultrasound also at that time, probably you would have also picked up on ultrasound. Hence, this good study which showed about the role of magnetic imaging, they found out that when the dedicated neurosonography was performed, additional findings were seen on MRI in only 5% of the cases, but only when a standard assessment of the fetal brain was done in the axial plane, then 16.8% of the cases had additional finding. Hence, MRI should be in your scheme of things, especially if you find that you're not finding any cause here, and you find a little progression which is happening in the size of the lateral ventricles. Definitely an MRI is indicated, and the commonest abnormalities, additional abnormalities that you find are malformations of cortical development and callosal anomalies. Step 9 is serial scans. Now, literature review says, we know ventriculomegaly has a natural history, though you can have the ventricle, the size can either regress, it can remain stable, or it can progress. Now, when there is a regression, which happens in 34% of the cases, the risk of neurodevelopmental delay is 4.2%. When it remains stable in 56% of the cases, the risk of neurodevelopmental delay is 4.1%. So honestly speaking, if it regresses or it remains stable, there is no increased risk of neurodevelopmental delay. But when it progresses, which happens in 16% of the cases, there is a 16.6% risk of neurodevelopmental delay. Hence, progression also is a poor prognosticator. When should you follow up? When should you do the next scan? Depends on at what time you've done the primary diagnosis. But the gap between two scans should be at least 2 to 3 weeks. Anomaly is not visible initially, not just the lateral ventricles, but anomalies that you were not able to see or had not picked up at the time of the early scans. Maybe in 13% of the cases, you may find anomalies, CNS or extra CNS that you pick up when you follow up those patients. The step 10 is the most important and the most tricky one, and that is counseling. Now, before you get into counseling, what are the prognostic factors? Well, what are the ones which cause poor prognosis? The severity of ventriculomegaly, progression during pregnancy, head circumference smaller than expected for gestational age, not necessarily microcephaly, if there is an associated growth restriction, or there are abnormal genetic or infectious tests, the presence of associated anomalies, or there is an early onset severe ventriculomegaly, the prognosis is going to be really bad, the worst prognosis. What is the recurrence rate? The risk of recurrence depends upon what is the etiology. So after having done whatever comes as your cause for it, the risk will depend upon whatever, because the risk of recurrence will be what is the risk for that particular etiology. When the etiology is not revealed following a complete investigation, the risk of recurrence is low. Counseling is easier if associated anomalies are present, or abnormal CMA, or exome sequencing, or there is progression. Counseling is easy. Yes, you can say, okay, the prognosis is poor, but the poor outcome depending on the associated anomaly regardless of the size. But it is very tricky in isolated mild ventriculomegaly, especially at the time of the first diagnosis. You've done a scan at about 20 weeks, and you find that the lateral ventricles atrial width is 10.4, 10.5, nothing else that you can find in the brain. The extra CNS, everything is normal. That is the time the counseling is very difficult. How much do you reassure them, or you need to, because we know, so we may find something later on, this may progress. There is still a lot of genetic testing that needs to be done, and we need to rule out infections, we need to rule out genetic testing, hence it is tricky at that stage. So let us look at the outcomes of isolated ventriculomegaly. After you have done a neurosonogram, detailed anatomy scan, microarray, whole exome or infection screen has been done, and all this is normal, then we can say that this is isolated. And if the outcomes in the severe ventriculomegaly, of course, the survival in severe is also 88%, and with mild is 93 to 98%. The risk of normal neurodevelopmental outcomes is, even in severe ventriculomegaly, can be up to 40%. In moderate, 75 to 93%, and in mild ventriculomegaly, greater than 90%. This is coming from this paper which has come in 2020. And isolated severe ventriculomegaly, but you still need to be careful, because you may find in 9.5% of the cases, you may find additional abnormalities which you see postnatally, which you could not pick up prenatally. So with isolated mild ventriculomegaly of 10 to 12 millimeter, after a complete evaluation, women should be counseled that the outcome is favorable and the infant is likely to be normal. With isolated moderate ventriculomegaly of 13 to 15 millimeter, after a complete evaluation, women should be counseled that the outcome is favorable, but still there is an increased risk of neurodevelopmental disabilities. Now, because this is the only study which has looked into the outcomes. So otherwise, even with mild ventriculomegaly, different studies have given abnormal neurodevelopmental outcome from 1% to 11%. But one study, which was a large complete study, they said the risk of neurodevelopmental delay is about 6 to 7%, which is also there in the normal population. So how do we handle ventriculomegaly? Lateral width greater than 10 millimeter. This is a quick recap. Mild 10 to 12, moderate 12 to 15, severe greater than 15, unilateral or bilateral. If it is bilateral, whether it is symmetric or asymmetric. And do a neurosonogram, detailed anatomy evaluation, fetal echo. LV atrial width greater than 10 millimeter, associated anomalies, further testing based on the findings that you get. If it is isolated, do genetic testing, infection screen, MRI. I'm saying query, because MRI actually at 20 weeks may not be, but maybe for medical legal purposes, or maybe yes, you're not able to do a good neurosonogram, you can ask for it, and a follow-up or neurosonogram after 2 to 4 weeks. And if in the follow-up there is progression, definitely do an MRI again, and do an MRI so that you find any causes that you have not been able to pick up on your neurosonogram. If it remains stable, you may still give an option of an MRI, but not necessary. But if it regresses, then generally the outcomes are very, very good. So if I look at this whole thing, how we have been handling it, there are 3 times that we need to do counseling. First, after the scan that you have done, you need to counsel the patient. Then you tell them all the tests that you need to do, get them done, and then you counsel them. And after that, you do a serial evaluation and then do counseling. And this is very difficult. In real life, you need to decide, do you do stepwise counseling? Like you've done this and you say this is isolated, and then you counsel them and say this is good, this is isolated, we will do some genetic test and all. They come normal, and then you say, okay, all this is normal, but we'll still have to rule out, any progression. So we'll do serial evaluation, or then you tell everything right in the beginning. Now, ideally, in today's era, you need to tell everything right in the beginning, that yes, even if these tests come normal, we may still have to do serial scans. If there is a progression, the outcome may not be as good even after these tests which have come normal. And usually when you tell them all this, I find very few people who actually decide to continue with the pregnancy. Hence, this is a very, very tricky situation. So my last words are that ventriculomegaly is just a finding, not a diagnosis. Isolated ventriculomegaly, don't use it easily. It's a diagnosis of exclusion. You need to rule out everything before calling it as isolated. And so make sure it is isolated before you say that to the patient. A very common scenario after this lecture is some question, but one question which commonly is asked, what if the atrial width is 9 to 7 millimeter? We know the normal atrial width is 6 to 8 millimeter. The 10 millimeter is actually nearly 3 to 4 standard deviation above the mean, but we use that criteria. 9.7, I will not call it as ventriculomegaly. I'm not going to put them into a battery of tests, but I will definitely ask them for a follow-up after 2 weeks or so. And then if I find that it crosses 10 millimeter, that is the time when I will start my protocol for ventriculomegaly. Thank you. Thank you very much.
Thank
Dr.
you.
Bimal,
Yeah.
sorry, yeah.
Yeah, sir, please.
Srinath.
Yeah. Dr. Mohit, please. Yeah.
Yeah, that was clearly the most comprehensive and exhaustive, demonstration of ventriculomegaly. I think you covered everything, and the recent updates were mind-boggling. The neurodevelopmental outcomes. See, we as radiologists, sonologists of fetal medicine, we have to understand that picking up anomaly is just one step. The most important step is counseling. And this is where I think Dr. Bimal has comprehensively covered that part. So tomorrow when you get a case of ventriculomegaly, you exactly know what needs to be done. So Dr. Gina, Dr. Rima, you can now begin the question answers.
No, I think we have
Yeah, we'll have the cases
three.
first.
Oh yeah,
We'll have
case.
three cases first, and then after that we can proceed with the question and answers. But I think we need to have the trade videos now, and then I'll introduce the. So thank you so much, Dr. Bimal, sir. I mean, this is the first time that I've heard this new talk of yours, because I've listened to your ventriculomegaly talks earlier, but this is simply mind-blowing and I'm speechless. Thank you so much. So now we come to our case presentations. So we have three presenters today. Dr. Bhargav Das, and he's from Guwahati and a radiologist trained in fetal medicine from Scholar MD, and he works in Life Care Diagnostic Guwahati. And then we have Dr. Zora Ahmed from Guwahati also, and she's done her MD radiodiagnosis from AIMS, New Delhi, and she's also a fellow of Royal College of Radiology, and also a fellow in Advanced Obs and Gynae Ultrasound from Mediscan Systems, Chennai. And then we have Goto Carlo, Dr. Goto Carlo from Arunachal Pradesh. And he's also an MD radiodiagnosis, done his MBBS from JIPMER Pondicherry, and is an MD from PGI Chandigarh, and is presently working in HEMA Hospitals and Quantum Diagnostics, Itanagar. So first we begin with Dr. Bhargav Das, and he shall be presenting on mild ventriculomegaly as a second trimester aneuploidy marker for trisomy 21. So you may share your screen, Dr. Bhargav.
Thank you, ma'am. Good evening, everyone. Respected teachers, mentors, and dear colleagues. I'd like to begin by expressing my sincere gratitude to the Society of Fetal Medicine and Northeast chapter, especially Dr. Gina ma'am, for providing me with this incredible opportunity to present a case and engage with such distinguished group of professionals and experts in the field of fetal medicine. Thank you, Dr. Bimal Sahani sir, for the wonderful lecture on fetal ventriculomegaly. It's been insightful. I would like to continue today's webinar by presenting a case of mild ventriculomegaly as a second trimester marker for trisomy 21. So history and clinical information. We have a 20-year-old female primary gravida referred for a second trimester anomaly scan. No evidence of consanguinity, no family history of genetic disease, past history of aneuploidy or pneumatoid disorder. No significant travel history. The menstrual age of the patient is 23 weeks, 0 days. Dating scan were done outside, which corresponds to the menstrual age. However, the 11 to 13 week scan was not done. The biochemical markers were also not done. So what we got when we started a scan, we first scanned the fetal brain, and we found that the lateral ventricles are dilated. The right lateral ventricle is around 10.9 mm and the left lateral ventricle is around 10.7 mm. So when we got ventriculomegaly, when we saw the dilated ventricles, the thing that came to my mind is I need to check the central nervous system of the patient, both the spine as well as the brain. And secondly, the soft markers of aneuploidy. This is because because of the meta-analysis that is done by Hydrocephalus, in which he has enumerated some soft markers. One of the soft markers is ventriculomegaly. So when I got a soft marker, we have to look for other soft markers of soft markers of trisomy 21, because if we get multiple soft markers, the likelihood ratio increases and the chances of trisomy 21 also increases. So keeping that in mind, I meticulously search for the soft markers. However, the soft markers were absent. The nasal bone was there. The long bones are normal. We have a umbilical arteries are normal. There's no pilectasis, and everything is normal. Then we did a dedicated fetal echo. The four-chamber view is normal. The outflow tracts are normal. The three-vessel view and three-vessel trachea view is normal. No evidence of ARSA. The ductal arch and the aortic arch are normal. And the biometries and the growth profile is also normal. Then the next step is to check the fetal neurosonogram. As Bimal Sani sir had said, fetal neurosonogram is a very important step in a case of ventriculomegaly. So ideally, it needs to be done in a transvaginal scan. But in our case, the patient, the baby is in breast presentation, so we have to do a transabdominal neurosonogram. In a transabdominal neurosonogram, we did the extended planes, the transcoronal and the sagittal planes. Except the mildly prominent ventricles, mildly dilated ventricles, the rest are normal. The corpus callosum, the posterior fossa, cerebellum, everything appears normal. The posterior fossa is also normal. The midbrain cavum septum pellucidum is normal. And also, while examining the spine, the fetal spine appears normal. There's no evidence of any neural tube defect, no defect in the vertebrae and all. So in the USG findings in the second trimester scan, we came to a USG finding of apparently isolated bilateral symmetric mild ventriculomegaly. No other soft markers were present. No other structural CNS or non-CNS abnormalities we can detect. The Leica is adequate and the fetus has a normal biometry. So at this point, the next step is counseling, how to counsel the patient. So we have to follow some protocols and like guidelines, how to counsel the patient. We have some wonderful guidelines from the published in Society for Maternal and Fetal Medicine, where they say how and what to do and how to guide the patient for a case of ventriculomegaly. So as it is a mild ventriculomegaly, we have to make the couple understand there are probable associations of mild ventriculomegaly. It can have genetic associations, structural anomalies, and infections. Also about the nasal course of ventriculomegaly. So the ventriculomegaly can regress, it can progress, it can remain stagnant. So the thing is that we have to also reassure the patient that it is a case of mild ventriculomegaly. Survival for newborns with isolated mild ventriculomegaly is high, with reported rates of approximately 93 to 98%. The likelihood of normal neurodevelopmental delay outcome is more than 90%. But we need to rule out everything. So we need to rule out chromosomal abnormalities and infections. And then only we can say it's a truly isolated mild ventriculomegaly. So we advise the patient to undergo amniocentesis and karyotyping and other genetic analysis. Also, we need to rule out infections, fetal infections that can be done from the serum as well as amniotic fluid. And if the patient is reluctant, we give the option of NIPT. So in our case, the patient agreed for amniocentesis, the patient underwent amniocentesis, and because our gestational age is around 23 weeks, we have running short of time. We ask for a QF-PCR, get a quick reporting of the patient, and trisomy 21 was detected. So the take-home message from our case is we cannot underestimate mild ventriculomegaly, even if there is no abnormality associated in anomaly scan. We do everything possible. We rule out everything. Even therefore, amniocentesis plays a crucial role here. We have to convince the patient to undergo amniocentesis so that we can rule out everything. And when everything is ruled out, isolated ventriculomegaly, and provided it's not progressing, we can reassure the patient that the likely outcome of the baby is positive, and we can encourage that the patient can continue the pregnancy. Thank you.
I think you can, yeah. Thank you, Dr. Bhargav. That was a fantastic, very well worked up case. And indeed, the fact that you could, convince the patient for an amniocentesis that was the main thing which led to the diagnosis. So congratulations. And our next speaker now is Dr. Zora Ahmed, and she will be presenting on mild ventriculomegaly, a normal variant or something sinister. So over to you, Dr. Zora. Zora, you're muted. I think you need to unmute.
I'm sorry.
Yeah.
So,
you can start again.
Good evening, everyone. A very good evening to all seniors, teachers, and colleagues. At the outset, I want to thank Bimal Sani sir for such a wonderful talk. It was truly enlightening, and really grateful to him for sharing his approach to ventriculomegaly, especially the counseling part. So I'll move on with the cases. So 36-year-old lady, Mrs. F, IVF conception. She had a prior 2.5-year-old healthy male child, also an IVF conception. Her present pregnancy is a DCDA twin pregnancy. So she came to us for a first trimester anomaly scan. Twin A, the NT-NB was normal. There was tricuspid regurgitation, DVA wave reversal, pelvic testis, and LV echogenic intracardiac focus. So there were multiple aneuploidy markers present. Lateral ventricle was normal, heart was normal. Fetus B had a normal first trimester anomaly scan, no aneuploidy markers, heart, lateral ventricle was normal. So first trimester screening was done, and beta HCG was high, 2.96 moms. PAPA was low, 0.83 moms. And the risk came as high, 1:67 for twin A, and was normal for twin B. That is 1:8584. So at that point, she was advised for an early anomaly scan at 16 weeks, followed by amniocentesis. So she came for early anomaly scan at 16 weeks, by which point DV had become normal, pelvic testis had resolved. However, there was tricuspid regurgitation, umbilical artery showed a high resistance flow. Heart was normal, nasal bone was present, and there was evolving mild ventriculomegaly measuring approximately 9 to 10 millimeters. On the other hand, twin B had a normal scan with normal lateral ventricles and structures. So it was suggested to the patient to undergo amniocentesis for QF-PCR and karyotype of both the fetuses. So amniocentesis was done by Gina ma'am, and these are the karyotype reports of the two fetuses. So fetus A with multiple aneuploidy markers and evolving ventriculomegaly at 16 weeks was trisomy 21. Fetus B had a normal karyotype. So patient was initially undecided about selective reduction, and finally she was referred for selective reduction at 24 weeks. Scan done at 24 weeks, fetus A had the only abnormal finding was a mild ventriculomegaly, which actually was not even ventriculomegaly, it was 9.1 mm. And the rest of the scan was normal. Fetus B was normal. And so at this point, she was counseled for a higher risk of miscarriage post fetal reduction. She was also given the option for a late reduction in the third trimester. But the problem was that the only anomaly was mild ventriculomegaly, which may even become normal by the third trimester. So the patient and the referring OBGYN decided for reduction now. So selective fetal reduction was done at 24 weeks of fetus A. So she's currently 27 to 28 weeks and she's under follow-up. Companion case, Mrs. A, 40 years old, Rh negative pregnancy, previous healthy son. So in this pregnancy, it was a natural conception. First trimester scan was normal. NIPT was low risk. And she came for anomaly scan. The growth was normal. And there was isolated mild unilateral ventriculomegaly. CSP was normal. Lateral ventricular margin was smooth. Ventricular contents were normal. Corpus callosum was normal. There was no other aneuploidy marker, no signs of fetal infection. So she was suggested torch, which also came out to be normal. And she was offered direct testing, which was normal. Thereafter, she was followed up serially. And initially, the unilateral ventriculomegaly increased from 10.6 to 11.4 mm. And then gradually in the third trimester, it reduced to 8.6 mm. And the rest of the sulcation and neurosonogram was normal. The left ventricle was normal to start with. So the take-home message from these two cases is that mild ventriculomegaly is a sign of a possible disorder and not a disorder by itself. It is isolated if no other abnormal intracranial or extracranial findings. As a marker of trisomy 21, likelihood ratio of isolated mild ventriculomegaly is 3.81. If we have a case of isolated ventriculomegaly, we have to do a neurosonogram, look for other aneuploidy markers, signs of infection. We have to rule out infection by torch and offer invasive testing. If there is truly isolated mild ventriculomegaly, then abnormal neurodevelopmental outcome is 10%. Thank you very much for patient listening.
Okay, thank you so much, Dr. Zora. That was a fantastic presentation. And our third and last speaker for the evening is Dr. Goto Carlo. Dr. Goto, I think, is a gem we found this time in during our outreach program in Arunachal Pradesh. And I call that, a gem in the land of the Dawnlit Mountains. So he shall be presenting on ventriculomegaly in neural tube defects. So over to you, Dr. Goto.
Thank you, ma'am. Evening, teachers, seniors, and colleagues. Today, I will be presenting a straightforward case of a neural tube defect with ventriculomegaly. This patient was an 18 years old female, primary, came at around 4 months of age, not sure of dates, no prior checkups were done, was sent for first antenatal scan, and it was a non-consanguineous marriage. The USG revealed a single live intrauterine fetus with a heart rate of 149 beats per minute. It was in longitudinal lie and breech presentation. Placenta was posterior upper body and fundal region. Lichen was adequate. Fetal biometry, BPD corresponded to 16 weeks, 3 days. HC corresponded to 16 weeks, 2 days. AC corresponded to 18 weeks and 2 days. And FL to 18 weeks. On axial sections of fetal cranium, there was mild bilateral lateral ventriculomegaly, symmetrical, with smooth outline, with a transatrial width of around 11 mm. There was apparently a thin cavum septum pellucidum appeared thin, and there was inward bowing of the bilateral frontal calvarium, which is known as lemon sign, and also a small cystic space, which is seen just behind the CSP, which is prominent cavum valve interpositae, which is known as a diamond sign. There's a lemon for you. And next, at the level of cerebellum, there was a cerebellum showed abnormal sausage-shaped cerebellum shape with anterior concavity, and cisternum magna was obliterated, and there was a suggestion of big tectum. On USG scan of fetal spine, there was at the level of L2, L3, there was evidence of meningomyelocele, which was evident by this interrupted continuity of the skin and subcutaneous soft tissue at this level, with the splaying of the posterior ossific center forming a U-shaped, with interrupted. Although this image is not so good, but still there was interrupted row of posterior ossific centers on the sagittal section. There was also associated kyphoscoliosis. On USG of the fetal limbs, a short bilateral cleft fit, and other systems were normal. Summary of the finding whether there was an open neural tube defect of lumbar spine, meningomyelocele, mild bilateral symmetrical lateral ventriculomegaly, and BPD and HC were less than 5th percentile as compared to FL. Small posterior fossa with banana sign and lemon sign, suggesting cherry 2 malformation, and associated bilateral club foot. Further, a couple was explained in counsel regarding open spina bifida and cherry 2 malformation, and then was sent back to the referring clinician, and the couple opted for termination. Here, I'll just like to enumerate the intraspinal and intracranial findings of open spina bifida, which I've already shown. In addition, which I couldn't show was the coronal sections. On coronal section to the spine, there will be you can actually see the defect with the increase in intrapedicular distance. And a word of caution here would be regarding myeloscasis. Here, where you may not see a very obvious cystic lesion. So in this case, in such case, we may miss the neural tube defect. So it's better that we evaluate the fetal spine in spine anterior position, and when the fetus is not opposed to the uterine wall, and better to use a high resolution probe. Intracranial findings, as I've already said, lemon sign, which can also be seen in 1% of normal fetuses, and the banana sign. And other associated lower limb neuromuscular sequelae, which in our case we saw, is talipus and rocker bottom foot, and even some of them can have frank arthrogryposis. Usually, in case of open spina bifida, usually genetic testing is not warranted unless if there's associated any other findings which may suggest otherwise. Just to add on this is that we can do a screening of open neural defect at the age of 11 to 14 weeks during the NT scan time by using certain subjective and objective criteria. Here, what we do is, as you can see, this is the brainstem, then brainstem occipital bone distance. We measure this, and then this is the case of two cases of open spina bifida where brainstem thickness is more than the BSOV. It should be emphasized to the patient that diagnosis of OSV is made only if you can see the actual defect, and not by the intracranial findings alone. Occasionally, we can also see a lemon sign and banana sign at the age of 13 to 14 weeks. Associated this kyphoscoliosis, hydrocephalus, and limb neuromuscular sequelae are usually seen in the second and third trimesters. Thank you. Thank you, ma'am.
Thank you, Dr. Goto. That was an amazing presentation. Congratulations.
Thank you,
And
ma'am.
now we should go over to the question and answer sessions and the comments by the experts, Dr. Mohit Shah and Dr. Reema Bhatt. And there are many questions in the chat box. So will you take them up, Dr. Reema? Yeah.
Yes, sure. I think that was a brilliant presentation by Vimal sir and all the participants. Excellent cases. Thank you so much. So we'll go on to the questions.
Can you unshare your
Sorry,
presentation,
sir.
Doctor?
Sorry, I forgot that.
So one question put up by Dr. Anupama is, do you put your risk calculation in your report, sir? The question to Bimal, sir.
Yeah, you can the risk calculation, but then again you need to be careful that you take the first trimester screening result and then modify that with the likelihood ratio that you get, for ventriculomegaly that you get. But see, amongst all these markers, everybody calls ventriculomegaly a soft marker. Honestly speaking, I don't feel it's a soft marker at all. Ventriculomegaly is something which is, far more than just being a soft marker for trisomy 21. So, maybe yes, just for that particular part, yes, you can have the risk assessment and modify the risk. Otherwise, like if you have an NIPT which has been done, now they say that you don't need to modify with second trimester soft markers. But I think ventriculomegaly stands a little different than all the other 7 markers that you have.
Right, sir. So I think ventriculomegaly, we are always worried, sir. So something is coming up around the corner. Thank you, sir. Sir, how do you proceed if you find mild ventriculomegaly at 32 weeks growth scan?
Yeah. Okay, you proceed in the sense yes, you are going to follow the same stuff. You are going to go do a neurosonogram. In fact, 32 weeks, if it is a cephalic presentation, you're going to get wonderful images. You go about looking at all that. And then, of course, you are going to counsel the patient as regards everything that you would have done otherwise before. Now, at that stage, whether to go for further testing or not to go for further testing would be an option which the patient has to decide on. But we would, and even an option of, if you're not able to really get a good CNS evaluation, an option of MRI. So I don't think I'm going to change too much. Only thing is I'm going to inform the patient about all these things. But because it's a 32 weeks pregnancy, anyway, by the time you finish off with these reports and all that, by the time they come, the patient would be on the verge of delivery. So a lot of patients may not opt for it, but as far as informing them about it, you need to do all what you would have done before also.
Thank you, sir. And also, if the liquor is very increased, sir, and mild ventriculomegaly is there, sometimes it's a reflection of deranged sugars. So sugar testing should be done for these patients, and liquor, we should keep a close watch that could be responsible for the mild
Yes, ma'am.
ventriculomegaly.
Yes.
Thank you,
La-
sir.
large babies, yes.
Large, yes, sir. So I think, Dr. Harshita, that sorts your question. Our next question by Dr. Shruti is, sir, is it possible that we find mild ventriculomegaly at 19 weeks and normal ventricular diameter at 27 weeks? How do
Yes.
we counsel these patients?
Yes, that is what I said. Ventriculomegaly has a natural history. So, in fact, I showed the figures also. In nearly about 30-35% of them, it is going to regress. And hence, that is something which is possible. And that's pretty good for the patient. I don't think, because if it was there, you've already done the remaining things. And if it has regressed, the outcomes are going to be very, very good. A very positive thing for the patient, actually.
Yes, sir. Your slide had showed in all that it can regress in some cases, and therefore that's a good prognosis. Another question by Dr. Avinash is, sir, why is the head size or biometry more in breech presentation?
I don't find that we find it more. Actually, we do get more of dolichocephalic heads in bridge presentation, but otherwise the head perimeter does not get altered in bridge presentation. Because yes, in fact you may get a BPD which is appearing lesser because of and then in a bridge presentation, the moment you creep, if it's a very thin pressure patient, you will actually find the head otherwise because of your pressure also becomes little dolichocephalic. But only thing, yes, in a bridge presentation, I would be more cautious in calling mega cisterna magna and all, because they do, apparently appear larger than normal. But I don't feel there is any. I haven't noticed that head circumference is larger in bridge presentation.
Right. Thank you, sir.
They-
Dr. Bharti wants to know what is the normal size of fourth and third ventricle during a routine scan?
Fourth ventricle, as such, we don't go about measuring it. In fact, we go by for the fourth ventricular index and all. Third ventricle, the width of the third ventricle, yes, there are normograms, but roughly I would say that 19 to 22 weeks is about 1.4 millimeter, and from 19 to 21, and then 20, because I had it by heart, because from 22 to 27 it is 1.5, and then every 2 weeks and 3 weeks it keeps increasing by 0.1 millimeter. That's the third ventricular width. Fourth ventricle as such, we don't have I haven't seen a biometry as such for a fourth ventricle. Anyone can add to that if
Yes. The only thing, sir, that they, yes,
10 millimeters
Mohit,
considered.
Mohit sir is saying some. So Mohit sir, you want to add something?
I think the fourth ventricle AP diameter more than 10 millimeters is considered significant dilated.
okay, the
AP. But fourth ventricle. And third ventricle, obviously, if it is seen very well, then it is abnormal subjectively, and objective criteria you have laid down.
Yes, sir. Only thing is that the width of the fourth ventricle should be more than the length.
Yes.
Otherwise, it's a pointer to a chromosomal problem. So
Right.
that we need to keep in our mind when we're looking at the fourth ventricle. And as Bimal sir also emphasizes that we must always document the fourth ventricle when we are doing our axial planes of the cerebral.
Actually, it is more of a marker. If you find that the side to side diameter is more than the craniocaudal diameter, that is normally there. But if you find that the craniocaudal diameter is more than the side to side, that ratio is what we call as the fourth ventricular index. Actually, it is a very good marker for malformations, the hindbrain and midbrain anomalies, actually, like rhombencephalosynopsis, Joubert syndrome. For all that, it is a marker for that, actually.
Thank you, sir. And so there are a lot of thank you for this wonderful talk, Bimal sir, by you. They also want to know that while doing neurosonogram, how to get good resolution and optimum views. Dr. Dipali has this question.
You need to come down to my center for a few days. Actually, it is, you need to, yes, you need to go ahead for transvaginal. I would say that you need to start doing a neurosonogram in 100 cases as a part of routine. I tell all my students that don't wait for the day you have a ventriculomegaly or a CSP which is not seen and then you are going ahead. So when you start doing it as a part of routine, you start getting the mid-sag and the coronal planes, then automatically it will happen. Yes, the quality of machine and your settings also are important. Put all those things together. It's not rocket science. I used to feel that, initial days when I used to listen to Dr. Ramamurthy and see his images, and then he used to say, oh, the corpus callosum talks to you. And I used to feel that why the corpus callosum doesn't talk to me. But then once you start doing it, it just, everything starts falling into place.
Yes. And so one tip that you have to use the left hand also to stabilize the head when you're
Right.
doing a transvaginal
Immediately
ultrasound,
transvaginal, yes.
because it helps to stabilize and get you better views, right, sir?
Yeah, yeah.
Thank
And
you,
I
sir.
think somebody asked for first trimester, how do you diagnose ventriculomegaly in the first trimester? Now, first trimester, we don't use this criteria of 10 millimeter atrial width and all. It is just, first trimester, the choroid plexus normally fills up the lateral ventricle. Now, if you feel that, more than half of it's just filling more, just half of the lateral ventricle, that is subjectively you can do it. And then there is a very good article where you have the normograms. There you take a ratio of the choroid plexus length to the ventricular length, choroid plexus area to the ventricular area, and choroid plexus diameter to the ventricular diameter. When you take that ratio, there are normograms for that, and that helps you. But it's mainly a subjective feeling. You just suddenly find that, oh, there is the lateral and medial wall of the lateral ventricle, the choroid plexus is not touching them, which normally it does. And it is just filling half of the lateral ventricle. That is sufficient to say that we are dealing with the ventriculomegaly.
Right. Thank you, sir. And Dr. Bharti wants to know workup of a unilateral ventriculomegaly at 30 weeks period of gestation. Unilateral ventriculomegaly at 30 weeks, sir. 30 weeks of gestation.
As I said, as of today, we are not differentiating as far as how we go further with bilateral or unilateral. Yes, evidence is coming that unilateral are not, especially chromosomal association was not, as that study which has come from the MRI group actually had shown that it was not very high. There was no chromosomal association, and even neurodevelopmental outcomes were nearly what was seen there. But as of today, we don't have enough to say that no, we don't need to worry about it. But yes, see, we are talking about 30, 32 weeks. As I said, we will put everything to the patient. We are going to put everything to the patient and tell them, yes, there is a chance for this. Yes, if they want to. Unilateral, I would definitely 30 weeks if I see, if I don't find anything on ultrasound, I would probably ask for an MRI.
True.
Because
any malformations of cortical development, you would definitely want
any changes of for infection, and in fact I will look for changes of infection, look for calcification, look for all these things, because unilateral generally the cause could be ischemia or infection there.
Yes, right, sir. So you'll give these choices to the patient. Ultimately, patient takes the decision, but you have to offer everything even at 30 weeks, like we are doing at a 22-week scan. So, sir, and again, the same question, that should all ventriculomegaly undergo amniocentesis? So, yes, we have to at least offer it to the patient.
Yeah, 7-8 years back, 10 years back, I used to say no. Why? But today, yes, all of them need to be offered a genetic testing.
Yes, sir.
And I think 3-4 years down the line, it's straight away going to be a WAS.
Yes, true, sir.
Even the microarray will go out of picture.
So Dr. Rekha wants to know, is dual test conclusive in multiple pregnancy? So yes, dual test is used for screening for aneuploidy even in multiple pregnancy, and combined first trimester screening is the best way of screening even in a multiple pregnancy. Sir, I think you will agree with me on that.
But the NT becomes quite important in a twin pregnancy.
And also the chorionicity is important. So, Dr. Bharti wants to know role of NIPT in isolated mild ventriculomegaly. So where does NIPT stand?
Yeah, see, NIPT stands as long as you consider it as a soft marker. So it's still, we would say that it is as an isolated marker, but then even if we go by the calculation with a likelihood ratio of 3.8, then if the patient is not willing for an invasive, then yes, at least to rule out, decent level trisomy 21 and to some extent 13 and 18 we can offer an NIPT. But I think we should start, I don't know whether you all agree, but I think ventriculomegaly we should start thinking more in, start putting it into a structural finding rather than just a soft marker, because really seen cases where it just appears absolutely fine, just a finding like that. But and then especially for the years when we were doing our scans at around 19 to 20 weeks only, and then 23 weeks, suddenly you find that you are able to pick up different findings for that.
True. So NIPT has got a very limited role, but yes, if patient is not willing for amniocentesis, at least a torch testing and NIPT to rule out
I would say
infections.
torch for everyone. Even at 30 weeks, I would still go for a torch test. Torch is something which actually is very important. We don't give so much importance to fetal infection, but yes, as I said, 5% of them, the cause is fetal infection, and hence torch. Even before thinking of invasive, you need to do maternal torch testing.
Serology.
Yeah,
Yes, sir. Yes, thank you so much. And how to calculate risk if more than 2 soft markers are present? Dr. Dipali wants to know.
Separate lecture some other
Yes.
time, whenever Gina calls. The mathematics of soft markers.
Okay, so again, that first trimester, you've already answered this question for all of them. So another, Dr. Shalini is asking a difficult question: how to look for optic tract to rule out SOD in case of absent cavum septum pellucidum. So I think that will also be another talk, or would you want to take this question?
Yeah, but you want to start looking at the optic chiasma, the best way to do is to start, you put in color and you get the circle of Willis, and within the circle of Willis, you will find, an X-shaped structure, and that is the optic chiasma. And then you actually, just hold that and turn your probe and get a coronal. That is it. At that level, you measure the width of the optic chiasma, and there are normograms for that. And once you have that, you would know whether the optic chiasma is less than the 5th centile. But let me tell you, a prenatal diagnosis of SOD is very difficult, very, very difficult. Even postnatally also, till the postnatal tests may also be very, very unsure till the time the ophthalmic evaluation and everything takes place. So SOD for us, I think prenatally should always be a differential diagnosis, but and it could be just an isolated septal agenesis. So, and that actually has very good outcome.
Yes, sir.
Can I add something here?
Yeah,
yes,
please.
Mohit, sir.
So even if you see an optic chiasm and even if it is normal, you cannot definitively see the optic tracts. So we don't know whether there could be hypoplastic. So what literature says is even in spite of seeing an optic chiasm, there's a 20% chance that the child could still be blind. So you need to counsel this patient that even though you are seeing the optic chiasm, there may be a 20% chance that the optic tracts may be hypoplastic and the child would land up with blindness. So that counseling has to be included when you encounter such a case.
Thank you, Mohit, sir. Okay, so the next question, we still have questions coming up, sir. So to diagnose microcephaly just on the basis of head circumference, or would you want to measure foramen magnum to cranium distance, FCD distance?
Yes, it increases the efficacy, because see, we really don't know below what cutoff should we call. Yes, -4 standard deviation below the mean, yes. But even when we take -3 standard deviation there below the mean, there would still be quite a few which would not be microcephaly at birth. -2, of course, is just a starting point for us. It's just a starting point for us. So yes, you can do the FCD as an additional thing. It takes care of, the problems associated with abnormal shape of the head and all. That is, now there is a protocol, and I think Gina is going to have one webinar on the microcephaly. So we'll have that covered up.
Right. So Dr. Nova, sir, wants to know that in first case, no first trimester combined screening was done. Is ventriculomegaly alone a reasonable indication for invasive testing?
I think that's for the first speaker who presented that case.
Yes. Dr. Bhargav presented.
Yes, ma'am. It is, as Sarah said, ventriculomegaly, we say it's a soft marker, but it's more than a soft marker actually. Even if the first trimester screening is not done, there are other causes of chromosomal abnormalities that needs to be ruled out, and amniocentesis is a must in a case of ventriculomegaly, even if it is a mild ventriculomegaly.
And I think we come to the last question, sir. If we have karyotype which is normal in ventriculomegaly, we can call it isolated.
No. Karyotype is just going to rule out the chromosomal abnormalities of number. That's all.
Yes. Yes.
Not the microdeletions and all. But I would say a bare minimum would be a chromosomal microarray.
And then there's infection.
That too when it's an isolated mild ventriculomegaly. If it is associated with other abnormalities and all, then of course, based on that, whether if you are thinking of something particular, otherwise an exome.
Thank you so much for those questions. Mohit sir, expert comments from you, sir.
Oh, this was fantastic. Bimal's talk was absolutely engaging, enlightening, wonderful, insightful. But I also would like to congratulate the three speakers, Bhargav Das, Dr. Zora, Dr. Gotu Carlo. You have done a wonderful job. I love the way you presented with such confidence. And Zora, of course, has been speaking with every webinar. So she's got a pro in speaking, but Dr. Bhargav, Dr. Gotu Carlo, probably it was your first time and you did wonderfully well. So keep it up. Let's keep this going. We need more and more participation from youngsters. I think this is a good platform to present your cases and get a national attention. Way to go. And the discussion was really good. The questions were pertinent to the topic and very clinically relevant in practice. So I think, Bimal, thank you so much for clearing all the doubts and all the fogs. And I know why this is so close to your heart, because you're a master in it. Thank you.
Thank you very much.
Thank you. And thank you to the organizers, Dr. Gina and President. Thank you so much.
Thank you all. Good night, everyone.
Good night, everyone.
Good night.
And thank you to our trade partner, Unipath. Thank you so much. And Vishal, thank you so much for always like picking up the phone and arranging everything. He's like a go-to person. And thank you, Dr. Mohit and Dr. Bimal sir and, Dr. Rima for joining in and giving us, sharing your knowledge, and to all the presenters from our chapter. And I hope that more and more people come forward to present because we really want that, our chapter to grow and, be much stronger, more people to come forward. Thank you so much.
Thank you. Thank you very much.
Good night.
Good night.